centre référé de la pédiatrie quand il développe l'urémie sévère urémie.
So, but you don't have an specialized pediatric dialysis unit.
No.
And you are taking care of these children as an adult nephrologist.
Oui.
Okay. Okay. I'm going to stress today on the point of differences between an adult and children dialysis prescriptions or dialysis, or different points in dialysis. You all know that the dialysis in adults starts in 1942. However, the first trial of dialysis in children was in 1949. It was in Boston. So the difference in the start is only 7 years. But on reality, the difference is more and more and more. And the dialysis in children is completely or almost different from an adult, and we are going to stress on these points during the presentation. We are going to cover all of these: when we should start dialysis, the facilities, the access, the equipment, the prescription, the frequency, duration, and the dialysis and adults. When should we start dialysis in a child? Usually it depends on the Schwartz formula to estimate the GFR in children. And the Schwartz formula is on the screen. We use the length of the patient divided by the serum creatinine times the constant, and this constant differs according to the age. You all know this graph about about the classification or the staging of the chronic kidney disease, and you will know that we start dialysis when we reach the stage 5, when the GFR is less than 15 milliliter per meter square surface area. However, we in children don't stick to the numbers, because we may start dialysis earlier there, and we may start dialysis with at a higher GFR level if we have an abort growth, poor development, worsening of school performance, or deterioration of the nutrition of the children. So yes, we consider the number, but don't stick to numbers. If the patient start to have a growth failure, poor development, worsening the school performance, or deterioration in the nutrition, so we can start dialysis at higher GFR levels. Sometimes we are faced by certain situations where we cannot do the dialysis, or we can start to think about starting dialysis even, or not starting dialysis even if these patients are in need of this dialysis. If the patient has a severe peripheral arterial disease, has a hypotensive heart failure, has a severe mental illness or a malignant disease with poor prognosis. So it needs an ethical decision. Is it ethical to not dialyze this patient or not? This needs an ethical decision rather than looking for the numbers or the condition of the patient. For the hemodialysis unit, the hemodialysis in children should be delivered in a pediatric dialysis center. The situation, or the kids are not a young adult, the kids are different, they are not little adult, but so they need a lot of people, a multidisciplinary team to deal with them. They need a doctor, they need a nurse, a social worker, a nutritionist, a school teacher even in the dialysis unit. These people are the new family of the child. For the number of the nurses in the unit, if we're looking just for the age of the patient, we can, or we must use one nurse for a child if he's younger than 5 years of age. But if we look for the Rogers classification, and this classification classify the patient characteristics for nurse assignment. And these Rogers looked for 7 categories from the psychological point of view: the mobility of the child, the vascular access, the teaching level, the stability of the child, the care level, and the weight of the child. And within each category, they have numbers from 1 through 4. And at each category, if the child has a 3 or 4 points, we should go to one-to-one nurse-child ratio. So, for example, if the patient has a severe adverse psychological insult, we should have 1-to-1. If the patient has a dual care, okay, slower. Okay. So the Rogers classification again depend or classify the patient's need or the patient characteristics for nurse assignment. And he considered 7 categories. And within each category, there are 4, from 1 to 4 points. And if the child has a 3 or 4 point within each category, he needs a 1-to-1 nurse to patient ratio. For example, if you have a child with 10 to 20 kilograms, he has 2 points, but if he has less than 10 kilograms, so he needs 1-to-1 nurse to child ratio. As I told you, because the children are different, so we should look for the environment of the unit. Appropriate bright colors, pictures, decorations are used to create a comfortable, relaxed setting for these children. The travel time to hemodialysis facility should be less than 30 minutes drive or at approximately 25 miles from the patient home. Usually, we don't use each station for more than 2 patients per day. And you all know that the distance around each bed should range from 10 times 11 feet per each machine. And this is very important to deal with the emergency of the patient and also for the infection control measures. The home hemodialysis is not till now recommended for children dialysis. For the infection control strategy, we should apply the infection control strategy for sure, but we should consider that this strategy or our children need a special need, and this strategy should not affect the psychological status of the child, not disturbing the joyful appearance of the unit, and sometimes the need for the attendance of the family member through sessions. So we should apply, but we should consider also that we are dealing with special patients and they may need some situations that may affect the infection control measures. We have a very, very stressful situation, which is when to not transfer the child from a pediatric unit to an adult unit. This is a mess. And usually we are facing the children who are refusing to be transferred from the children unit where they have a caregiver directed care to an adult unit where they will have a self-management. Also the situation or the underlying conditions are different from children to an adult, and the morbidities in adults are completely different from that of the children. He will be transferred to a unit where we have a 70 or an 80 years old man or guy with a heart disease or whatever the comorbidities of adult with chronic kidney disease are. So it needs a transition champions who are going to convince the child to move from the children unit to an adult unit. We don't have any difference in the water quality between the units or the children units and the adult units. For the vascular access, the preferred mode of a temporary access in children is the W central venous cap. But don't use the internal jugular vein on the same side of the planned or maturing upper limb fistula, and avoid the subclavian vein. For the permanent access, the preferred mode in our age group is the native arteriovenous fistula. We usually plan to insert the fistula or to create the fistula 6 to 12 months before starting hemodialysis. And we go to the non-dominant head, as you all know, or the non-dominant limb, as you all know. The first fistula cannulation is when to start this fistula cannulation. Usually we wait up to a month until we are sure that the fistula is mature enough. You know the Kiduki guidelines say that the percentage of cath in a dialysis unit for adult should be less than 10% of patients. But in our age group, we may have difficulties to stick to this number. Maybe we have more children or more patients without fistula through the other lines of access. Okay. For the equipment, again, the volumetric ultrafiltration control is the one or the preferred one, and we usually go to the OR if we have, because we have children right now in our country because the transplantation for children is still not that popular, so we have more patients on chronic hemodialysis, so it is preferred to go to the hemodifiltration rather than the classical hemodialysis or the conventional hemodialysis because it's more suitable. And if you look at this paper, which was published about 8 years ago, about the efficacy of the online hemodifiltration in children, this guy concluded that children, parents, and team care discovered a new way of life with motivated children, natural compliance, because they don't need to restrict the diet, and most of all these children developing with catch-up growth. So the hemodifiltration, if you have a facility for it, it is much more physiologic or much more or more suitable for children on chronic hemodialysis. I think this is the same in adult. The machine should be replaced after 7 to 10 years service, or after completing between 25,000 to 30,000 hours of use, depending upon the machine condition. Okay, for sure we are now using the bicarbonate dialysis. So let's move or stop for a time on the prescription of hemodialysis in children. The first point is how to estimate the dry weight in our patients. We have difficulties? Yes, we have. We do have. And why? Because number one, our patients are liable for more hypotensive episodes, hypotensive tendency. And number two, our patients are growing, so their dry body weight is not fixed. These are the methods that can be used for estimation of the dry weight. The atrial natriuretic peptide, serum level of atrial natriuretic peptide, the inferior vena cava diameter, the bioimpedance one, the hematocrit value. There is no ideal method for assessment of a dry weight in children. Because we are growing, or our children are growing, we have some concern about the type or about the size of the dialysis. But actually, for the type of dialysis, the synthetic modified cellulose low flux membrane can be used with, this is an evidence level, it's in a 2C. And these guys try to compare between different type of dialyzers, and they conclude that there is no evidence of benefit when synthetic membrane were compared with cellulose modified cellulose membrane in terms of reduced mortality, reduction in the dialysis related adverse symptom. But despite the relatively large number of randomized controlled trials undertaken in this area, none of the included studies reported any measure of the quality of life. So they did not find a difference between both types of dialysis, but they did not consider the quality of life when using or when comparing the two types of dialysis, or the different types of dialysis. So the use of more biocompatible dialyzer instead of unmodified cellulose seems justifiable on the basis of the evidence of biological benefits and equivalent cost. So if you have a patient or a children for chronic hemodialysis, we can use the more biocompatible dialyzers than the least. Again, the high flux should be considered, especially in chronic long term. For the size of the dialyzers, it depends on the weight of the children. So if you have a very young infant, less than 6 kilograms, we can go to 0.2. We actually have 0.2 dialyzers here, but which is very expensive, and now we have problems, as you all know, with the availability of these dialyzers. But again, the use of the dialyzer depend on the weight of the patient. You know why? Because the priming volume. So if you have we are not allowed to have more than 10% of the total body water of the child to be in the extracorporeal cell. So if you have a larger priming volume in a very young infant, he may develop a hypotension. The same situation in blood lines. It depends on the weight of the patient. If you have a child more than 20 kilograms, you can go to an adult one. But less than 20 kilograms, we have the neonatal line and the pediatric line. We don't have a neonatal line here, but we do have a pediatric line. Usually when we are obliged to do a dialysis in a young infant, we use a priming of the circuit with an expanders before starting dialysis or before connecting the patients to the circuit, to avoid, as I told you, the hypotension. We use this pump rate, which depends mainly on the surface area of the children. So it's 150 to 20 ml per minute per meter square surface area, or 5 to 7 ml per minute per kilo. We have these equations. If you have small children, we can calculate the pump rate. If we, according to this equation, the body weight plus 10 times 2.5 give you the appropriate pump rate for these children. In children, as an adult, we have the unfractionated heparin and the low molecular weight heparin. Each of them can be used. But we, as you, use a heparin-free dialysis when you have an active bleeding, pericarditis, coagulopathy, thrombocytopenia, intracerebral hemorrhage, recent surgery, or recent transplant. You can skip also this one. Okay. What is the frequency of dialysis and what is the duration of dialysis? Again, 3 sessions per week are the must. And for each session, we can go from 3 to 4 hours. We are not allowed to remove more than 5% of the dry body weight per session. And we don't allow our children to have more than 10% increase in the dry body weight in between the sessions. Is intensified hemodialysis more beneficial in children? Okay, this review compare different options, treatment options for children, and they conclude that the intensified hemodialysis modalities provide improvement in the quality of life, biochemical and the cardiovascular parameters, and likely anemia and nutrition. Okay, if you have a suitable solution, the intensified dialysis is expected to be or to become a prevalent choice in the treatment of end-stage renal disease. How we can assess the adequacy? We can go to the hemodialysis dose as you consider. Also for the laboratory indices, you also consider this, but we have a peculiar one, which is a clinical indices. You are familiar with that about the Kt over V. We consider to have a 1.2 value for Kt over V, and we should assess it monthly. And these are the laboratory indices. They are not different from them or from the indices in adult, but these are the peculiar for us, which are the clinical indices. We should assess the nutritional status of the children. And how? We can assess at first the mid-arm circumference to assess the muscle mass of these children, and according to the number we can classify the patient as having a severe malnutrition, moderate risk, or normal if the mid-arm circumference is more than 12.5 centimeters. We can assess the mass, the subcutaneous fat, by using what's called the triceps fold and the biceps fold. By special instrument, we can assess this fold. This is a biceps fold, or we can also assess the triceps fold. This is how to assess or to measure the body mass index. And for the clinical, the laboratory markers for the clinic or for the nutritional status, we can depend on albumin and the transferrin. But for the pre-albumin, we don't consider actually the pre-albumin because it's a variable and it is an inflammatory marker, so it may be affected by dialysis. So to assess the nutritional status, we measure the mid-arm circumference, the triceps and biceps fold, and the body mass index. The malnutrition or cachexia are prevalent in children with or on hemodialysis. Look at the numbers, about 18 to 56 of patients of children on hemodialysis have malnutrition. 1/3 of them, the malnutrition is mild to moderate, and almost 7% of them have severe malnutrition. You know the difference between malnutrition and cachexia. Malnutrition, there is a good adaptive response of the body. But in cachexia, it is a maladaptive response and the patient starts to eat his fat. Although this study was done on adults, but these guys, it's a very old study, but when they look for the nutritional status of the children, of adult or these adults who have been maintained on a very long period of hemodialysis, and despite the markers or the nutritional markers of dialysis are okay and the adequacy is good, these people develop malnutrition. So despite adequate dialysis dose and protein intake, patients treated with hemodialysis for a long period of time became malnourished, whereas the classical nutritional markers remained in the normal range. This figure shows the factors which are responsible for the development of malnutrition in the cachexia. It's a very complicated one. A huge number of factors are acting in this issue. But the point is, we have the cachexia or malnutrition is prevalent in our children on chronic hemodialysis. How to manage? We have a very big problem. These patients are anorexic. So if you have an access or a good surgeon who can do an gastrostomy tube, it's okay. And we can also use the intradiuretic amino acid or intradiuretic nutrition. So we can give this patient a certain type of fluid containing a special amount of amino acids, fats, and glucose. And there are special indication. They have a 3 months pre-dialysis serum albumin is at 3.4, the 3 months pre-dialysis serum creatinine is 8, the weight loss more than 10%. So there are special indication for initiating an intradiuretic parenteral nutrition. These are the concentrations that should have from amino acids, lipids, and glucose. But it is without this type of therapy is without side effect. They may develop hypophosphatemia, hypomagnesemia, hypokalemia. And if we look at this review about the evidence for the use of intradiuretic parenteral nutrition in malnourished hemodialysis patients, and they conclude that they only, when they did the systematic review, they only 3 randomized trials which you can depend upon, and only one of these trials investigating the clinical endpoint and where insufficient data to undertake the meta-analysis. So these are limitations of this review, and they conclude that the evidence from clinical studies is insufficient to demonstrate either a net benefit or a net harm associated with providing an intradiuretic parenteral nutrition to the malnourished hemodialysis patient. So it is there, but there is no strong evidence that this type of therapy or this type of nutrition may help these children or patients in general. Okay, the third point in assessment or in the clinical indices in assessment of the dialysis adequacy or is an assessment of growth and development. We should assess the weight of the children every 2 weeks, the head circumference and height every month, the tunnel staging every 6 months, and the school performance every year. The gross failure and the malnutrition is prevalent in our children, especially if those who develop an end stage or a chronic kidney disease early in life. This is because the growth of this group of children is mainly dependent on the nutritional status rather than the hormonal status. So the earlier the age, the more the affected the growth in these patients. Many factors are responsible for growth failure in these children. But if there is a room for growth hormone therapy in these children, it's a long algorithm. Because, as I mentioned, there are many factors responsible for growth failure, so don't go to growth hormone except after controlling the other factors that may affect the growth in these children. And we cannot, or it is not allowed to give a growth hormone for those who have enclosed epiphysis. So we should assess the epiphysis of these children and to be sure that there is still a chance for these children to grow. In these studies, again, it is a review, systemic review from the Cochrane. They review 16 studies about the use of growth hormone in managing these children, and they conclude that 1 year of growth hormone in children with CKD resulted in about 4 centimeter increase in height velocity above that of untreated patients. But still, there are certain limitations. The studies were too short to determine if continuing treatment resulted in an increase in the final adult height. Should we vaccinate our children? The answer is yes. Vaccination is recommended for the pre-end stage renal disease even before they become dialysis dependent. And children maintained on chronic hemodialysis show good tolerance to hepatitis B vaccine and mount a humoral immune response similar to a healthy adult with this, which is good for us. But we should assess the immunological status of these children serially to know, because you know this, the humoral response is lost by time, so we should assess the immunological status if they are still immune or not serially during follow-up of these patients. This issue is almost always neglected. We are treating patients, but we don't look at the quality of life of these patients. So, you know that the end stage have a severe impact on the quality of life, not only on the patients, but also of the parents of these patients. And regular assessment of the quality of life should be a must, including implementation of the patient-reported outcome. There must be a communication between the multidisciplinary team sharing in the management of these patients and also with the teachers of these patients in the school. These children, or the school teacher, should be aware of the physical limitation and the need for excused absence for the clinical visits. So, to sum up, hemodialysis for children should take place in a specialized pediatric centers able to provide a multidisciplinary support. A transfer process for adolescents must be in place and agreed by referring and receiving units. Dialyzers and lines must be available in neonatal, pediatric, and adult size. Synthetic and modified cellulose low flux membranes are recommended, but high flux membrane should be considered, especially in chronic long-term dialysis. A fistula should be considered in children in long-term dialysis. Vascular access surgery should be undertaken by an appropriate trained and skilled staff about 6 months or a year before initiating dialysis. A KT/V of 1.2 should be the minimum for children and should be checked monthly. The measurement of nutritional status and growth and the development should be used regularly as a part of the assessment of dialysis adults. Dry weight needs regular assessment in the growing child. And thank you for your attention.
Professor Ashraf for the elegant and interesting presentation, and the presentation is open for discussion. Any questions for Professor Ashraf? Yes, please.
In French, je vais parler en français. Merci beaucoup, professeur, pour cette brillante présentation. Au Togo, nous n'avons pas d'unité de néphrologie pédiatrique, comme la plupart d'entre nous. Et donc, nous prenons les enfants dans l'unité adulte. Nous avons de véritables problèmes parce que nous n'avons pas non plus de dialyse péritonéale que nous puissions les proposer. L'expérience montre que, en tout cas chez nous, le plus petit en âge que nous avons dialysé avait 33 mois. Donc vraiment petit. Mais nous n'avons pas du tout de ligne adaptée. On n'a pas du tout de ligne pédiatrique, on n'a que des lignes adultes. Les plus petits reins que nous avions étaient des reins de 1 mètre carré. Donc encore beaucoup que normalement, selon votre diapositive, on devrait utiliser au-delà de 20 kg. À 33 mois, évidemment, il n'a pas du tout ça. Alors, nous utilisons comme astuce un branchement ligne pleine. Mais j'avoue que c'est toujours aussi difficile. Dans ces conditions, qu'est-ce que vous nous conseillez? Parce que il y a beaucoup d'insuffisance rénale aiguë, certainement liées au paludisme, les hémolises, les intoxications. Mais est-ce qu'on va laisser ces enfants-là, parce que nous n'avons pas d'unité de dialyse pédiatrique, ou bien nous devons faire, ou bien attendre forcément que l'enfant ait 20 kg avant de pouvoir le prendre en charge? Parce que ça nous pose véritablement un problème. Qu'est-ce que vous pouvez nous conseiller dans ces conditions en attendant que, éventuellement, une unité de dialyse pédiatrique soit ouverte? Merci.
Okay. You all know what did he say? No. No, in English? He is asking that, or he is telling us that in Togo they don't have facilities for an hemodialysis for children, and they don't have also a staff or physicians who are expert in dealing with children, and the youngest age that they can manage than a 33 month was almost 20 kilos. And he's asking for the advice. what can they do? This is a situation not about, you can say, in 15 or 20 years ago, when we started the hemodialysis. First of all, you should have the will to start the activity in your unit. This is number one. Number two, which from my point of view is a very limiting one, is a logistic one. How you can convince the authority to offer these the consumable, I mean the dialyzers and the lines for treatment. And the third is to train the people, and I think the training of the people is the least one, and especially the nurses, the people, the physician and the nurses. So my advice, first of all, you should start by the older one as you start, and you should be taught how to perform a peritoneal dialysis for the acute cases, because that is maybe a life-saving one, and it's easy to be trained on, because the peritoneal dialysis, especially the acute one, is not that big issue. You can send one or two of your colleagues in the center to be trained in another one, but at first you should convince, as I told you, the authority to offer the consumable, because if you have a trained personnel without a consumable, you cannot do it. You can start by a small group of people to be trained, and you should talk with the authority to offer even for, we are not now thinking about the very young one, which has 5 or 6 or 7 kilometers, but at least for those who are an older or with a weight more than 15 or 12, the one which can be managed without a great care. But for the youngest one, I don't think you are now able to do that. So convince your authority, train some of your people. You should be trained on a peritoneal dialysis for an acute situation. That's it.
Any more questions? Yes.
Oui, merci beaucoup, professeur, pour votre exposé qui était complet et qui a mis en évidence et qui a mis l'accent sur notre défaillance. Je ne vais pas répéter parce que la première partie concerne exactement ce qui se passe autour. Maintenant, la deuxième question, c'est au cours de l'exposé, puisque le calcium et les troubles minéralo-osseux sont au centre de la croissance de l'enfant et l'utilisation de l'érythropoïétine chez les